Better to have go with introduction and some.
Okay, then I will start. Greetings and welcome to all. Just a few housekeeping issues first. Can I please ask you all to mute your microphone? And if possible, turn on your video so we can see you. If you have low bandwidth, you can keep the video off until we come to the Q&A session. If you have any questions, please type them in the chat box at any time. You can ask questions at any time by typing in the chat box. We don't take audio questions until the Q&A session. Please don't unmute until you are invited to unmute, otherwise we have too many people speaking at once. The webinars are recorded. You will see a recording of the whole video, and you will get the slide deck as well. It will be shared with all participants. So you get everything, both the video and the slide deck. So the main objective of this webinar is to allow you to ask questions. I will summarize the module and the key points and then ask questions. Experts are able to answer questions, but only if you ask the right questions will you get the right answers. So think carefully about the questions that you want to ask as we go through the summaries that I will present. And today, we'll take it in two parts. I will present for around 20 minutes, giving a summary of the module. Then we'll have the first Q&A session for around 10 minutes. You can ask questions. You put them in the chat box. I will work through the chat box. Then I'll present the second part for around 20 minutes. Then there'll be a slightly longer Q&A session of around 15 minutes. So two short presentations of around 20 minutes with Q&A sessions in between. I think you're all well familiar with me now. You've heard my voice so much as you work through the course. I think you know who I am by now, so I don't need to do all the introductions. So this rational use of medicines, what do we actually mean by rational use? And throughout the course, we try to stay with the WHO definitions. And we're again using the WHO definition. That means the right drug in the right amount for the right duration at the right cost. A little bit of a debate. In the past, the definition was the lowest cost. We tend not to use that anymore because that means the cheapest, and that's not always the case. We talk about total cost of ownership, so we're going to say the right cost. So that's all that rational medicine use is. We use the right drug. We define the right drug as being from the standard treatment guidelines. That's the right drug. The duration, again, is from the standard treatment guidelines. And the quantity, the dosage, again, is from the standard treatment guidelines. That's what we mean by rational medicine use or rational drug use. Well, why is it so important, this rational medicine use? I think you've seen this chart quite a few times throughout the course. It's one we did way back in 1980, but it's still current, it still works, it still follows. If we look at how much benefit the medicine that we buy actually does, and we call that the therapeutic benefit. So if I buy $100 of medicine, how much of it actually does any good? And in a typical situation, the answer is only about 30%, because some is lost through expiry, and some is lost through poor storage, and some is bad quality, and some I paid too high a price for it, so I wasted money. But the biggest areas of waste, if you look, is the pink at 21%, which is lack of adherence by patients. And that means the patient doesn't take the medicine, or takes it for 1 or 2 days and then stops. And the second one is irrational prescribing. The patient's not getting the right medicine. So those two areas are a big waste of money. But with just a little basic management, we can turn the situation around from 30% benefit with 70% wastage to 70% benefit and 30% wastage. To get beyond 70% benefit, we have to get really well organized and structured. And that's hard for most low and middle income countries because it's very hard for us to get enough finance and support to achieve that. But to get to 70%, all we need is basic management procedures. But the key point is the major area of wastage is not expiry or theft or poor quality. It is lack of adherence by patients and irrational prescribing. It's big money being wasted. These two areas make up 30% of the 70% wastage. More than expiry, poor storage, theft, and quality issues all combined. It's the biggest area of wastage. And if I can improve those areas, I can improve my medicine efficiency by 50 to 70%. So this rational medicine use has a larger cost impact than almost anything else we do in procurement and supply chain management. We reduce expiry, we might save 7%, but here I could save 30% if I address these areas. But why is it so important? Well, there's another factor, which is antimicrobial resistance. If the patient is not receiving the correct medicine, or the wrong dosage, or the wrong duration, there's an increased risk of antimicrobial resistance and adverse drug reactions, and that can cost an enormous amount of money. Right now, we're in a fight, we're in a war against bacteria, and it's a war that we're losing, because as fast as we invent new medicines, there are new bacteria that become resistant to them. So we're continually fighting. So we have to address antimicrobial resistance as a key area. Why is it important? Well, because it impacts PSM. If there's irrational medicine use, it distorts the usage pattern. I can just ask you to mute, please. If I can ask everyone to mute, please. So the way I calculate the quantification in consumption-based quantification is that I use the usage pattern. But if I've been using the wrong medicine, I've got the wrong usage pattern. So I calculate the wrong medicine. I calculate the wrong quantities. And then if I've got the wrong quantities, I get stockouts. And if there are stockouts, I can't have rational use because I haven't got the right medicine. So this is a circular argument. Stockouts drive irrational use. Irrational use drives poor quantification, which leads to stockouts. It goes round and round. If I don't break this cycle, I'm always going to be having stockouts, poor quantification, and irrational use. Well, that's all very good, Prof, but this is very academic. This is not supply chain. This is high-level academic pharmacy. It's nothing to do with procurement supply chain. We can't tell doctors how to prescribe, and we can't tell pharmacists how to dispense, and we can't tell patients how to take the pills. No, we can't. But we can ask the question, why? Why is there irrational use? And unfortunately, a large part of that answer is because we are failing in PSM. We are driving irrational use. We are creating irrational use through stockouts and through some of the procedures that we follow. That's a bold statement, but that's the realization of why PSM must be involved in rational medicine use, because we're a major part of the problem. If we look at antimicrobial resistance, WHO reports in Africa the two main drivers of antimicrobial resistance are stockouts and substandard medicines. How do we get stockouts? Because we are failing as PSM. We're failing to get the medicines there. Why have we got substandard medicines? Well, partly because we're buying rubbish, and then we're creating rubbish through poor storage and transportation. And sometimes we're doing both. We buy rubbish and then make it even worse with poor storage and transportation. Another reason is it's not just the medicines. If we're out of stock of diagnostics, particularly rapid test kits for HIV, malaria, then I can't diagnose properly. If I can't diagnose properly, I'm back to syndromic management. Patient's got a high fever, shivers and sweats, probably malaria. I'll give him antimalarials, but it might not be malaria. Without the diagnostic kits, I can't be sure. I might be giving the wrong medicine. So it's not just the medicines, it's all the health commodities. If I'm out of stock, if I have poor quality medicines, I am driving irrational use and antimicrobial resistance. Before COVID, this was already a problem. COVID has just made it a lot worse. Because of the fragile supply chain and all the disruptions we've got, I've got far more stockouts because of COVID, not on COVID-related commodities, nothing to do with COVID, but it's disrupted the supply chain, and that's brought me all these problems, which is increasing antimicrobial resistance. If we look at the situation, an example from the Philippines, they ran out of stock of category 1 TB medicines for about 1 month. About 2,600 patients couldn't get their regular TB medicines. That means because their treatment was interrupted halfway through, around 260 of the patients went on to develop MDR TB, multiple drug resistance TB. But they didn't just develop MDR TB, they went on to infect another 60 people with MDR TB, and those 60 people went on to infect more people with MDR TB. In total, around 600 people died because of the stockouts. But also, the people who survived with MDR TB, I then had to use much more expensive second-line TB medicines to treat the MDR TB. A first-line TB treatment kit, category 1, is about $30. Second-line treatment is about $3,000, 100 times more. This stockout cost about $8,000 per patient. If I'd have had the stock, it was $30 per patient. It's a massive cost impact because of the stockout that drove antimicrobial resistance. Similarly, on HIV, if I'm out of stock of antiretrovirals, it's calculated about 4% of the patients will die. And in figures from Côte d'Ivoire, Ivory Coast, we see that impact. Driving antimicrobial resistance so that first-line antiretrovirals no longer work, and I'm now stuck using second-line, much more expensive antiretroviral medicines. So the consequences of being out of stock is that I push irrational medicine. The physician's got to give something. I want to give them amoxicillin. I haven't got it. So I'll use ampicillin. That's irrational use, but I've got to treat the patient somehow. And that's what we do. I have to use a broader spectrum antibiotic. I have to use different tiers of antibiotics. And it lets in substandard medicines. If I haven't got it in stock, the patient may go to the market and try and buy it, and they'll buy often a substandard medicine from the marketplace. So if we look at the reasons for irrational use, we now see, why don't patients take the medicines? There are many reasons, but some of the reasons are the medicine's got a bad smell or a bad taste, or it's substandard and they don't like it and they won't take it. The prescribers, why don't the prescribers prescribe the correct medicine? Well, doctors aren't stupid, they know what to do, but they can't do it if I'm not in stock. If I haven't got the medicine, they can't prescribe the right medicine. What about in the workplace? If I'm out of stock of diagnostics, I can't give a definite diagnosis. I have to use syndromic medicine, and that might be irrational medicine use. The drug supply system, I'm out of stock, but also I'm not good at telling physicians when I'm back in stock. So they don't know that they can now use the correct medicine because I haven't told them I'm back in stock. And drug regulation, we're often buying medicines outside the essential medicine list. I shouldn't have those medicines. If I haven't got them, I can't use them, and I'm much more likely to get rational medicine use. So all across the feature, there is causation arising from PSM. PSM is not the only reason. There are many reasons as well, but PSM is a major factor in driving irrational use. That's why we as PSM have to address it. On the screen are some examples of poor quality tablets. Would you take these tablets? Then how can we blame the patients if they won't take the tablets when they look like this? This results from buying poor quality and/or poor quality during storage. If it deteriorates in storage, particularly if it's got a bad smell, the patients won't take it. I can't expect the patients to take the medicines when it looks like this. So we have to make sure that we are delivering quality medicines. It's one of the factors that drives lack of patient adherence. It's not the only factor, but it is an important one. Patients sometimes report the medicine has a bad smell, and we tend to ignore it. Oh, patients are always complaining. Not important to just ignore it. And some medicines do naturally have an unpleasant smell, but we should never ignore it. We should always take it seriously and investigate that situation, because that drives irrational use, and the medicine may be a problem. How many of you know what the specification is for a wooden forklift pallet that we store the medicines on in the warehouse? What specification is it? Many of you will know the specifications for the medicines, USP and BP, but what about the pallets? See, some wood pallets are treated with an antifungal chemical, which gets inside the bottles and makes the medicine smell bad. In the example shown on the screen in the USA, they had to destroy 54 million bottles of medicines because they used the wrong pallets. How many of you even know what the correct specification for a pallet is? This is a procurement supply chain management issue. We have to use the correct pallets. Otherwise, we can contaminate the medicine. We're trying to change to use plastic pallets, and then we don't get that problem. But if you are going to use a wood pallet, the specification is ISPM 15, sometimes called the wheat mark, because stamped on the pallet, sometimes on a metal plate, a little tin plate, stapled to the pallet, is this sign that looks a little bit like a wheat sheaf. And that gives you the specification, which is the pallet has been heat treated. Chemicals have not been used on the wood, so it's not going to contaminate our medicine. So reports of bad smell are important to us because they drive patient non-compliance, non-adherence. And that's a big area of wastage. We have to be aware to make sure that we as PSM are using the correct pallets and are doing our job in keeping the correct quality of the medicine. So the point about the irrational use is, as PSM, we must recognize it. In the past, many PSM people have tried to dismiss it. That's nothing to do with us. That's all the doctors and pharmacy. It's nothing to do with procurement supply chain. Yes, it is. We have a huge impact on rational medicine use, and it has a huge impact on us. We have to work to address these issues. It's a key part of what we do. It's not just the medicines. Other areas as well. I've talked about diagnostic, but we have an example when they ran out of prescription pads. And then the clinicians wrote prescriptions on all sorts of bits of paper. And irrational medicine prescribing increased greatly. So it's all items together: medicines, diagnostics, and health products. I can ask everyone to mute, please, until we get to the Q&A session. Okay, so what is this pharmacovigilance that's linked to this rational medicine use? Well, pharmacovigilance is making sure the medicine does not harm the patient. And PSM has only a partial role to play in that, but it's an important role. Are we sure the medicine reaching the patient is the correct quality? Have we bought the correct quality? Have we maintained the quality through storage and distribution? Key areas for us to address. And we use these terms: adverse drug reaction, adverse drug event. The definitions from WHO are on the screen. But in essence, what we mean is this medicine harming the patient because it is not of the specified quality? And that's the key point for us on pharmacovigilance. Have we maintained the quality of the medicine? Well, what's this got to do with PSM? Well, because it's reckoned that around 20% of the medicines in low and middle income countries that are dispensed to patients are substandard. They're below the quality specifications, partly because we're buying rubbish, partly because we're making rubbish through poor storage and distribution, and sometimes both. We buy rubbish and we make it worse with poor storage and distribution. That's the reality. We're not doing that well. We're not providing full quality medicines to patients. How does that happen? Well, through poor selection. We're buying medicines which we could never control the quality of with the resources that we've got. That's poor selection. We're undertaking poor procurement procedures. We've got procedures geared towards the lowest possible price. That's wrong. We have the lowest evaluated price. That's different. The total cost of ownership concept. We've been very poor on quality assurance procedures, on maintaining quality on arrival and throughout storage and distribution. And there is deterioration in storage and distribution. These are all PSM issues. And that's our contribution to pharmacovigilance. If we don't check the quality, if we don't have a pharmacovigilance program, we'll never know if we are harming the patient. And when we do check, we often find out that we are. And we need to change and drive better storage, better distribution, better procurement. How do we address these issues? Well, through standard operating procedures, through full procedures on quality assurance. And in the next module, we'll talk a lot about how we do quality assurance throughout the procurement supply chain. But the hard reality for us is that many of our PSM operations are weak, they're chronically underfunded, they're poorly implemented, and they're frankly not operating that well. How many of you have got storage systems that comply with WHO good storage practice, GSP. Maybe the central national store and 1 or 2 provincial stores, but after that, usually not. If the storage conditions are not good, the medicines can deteriorate. By monitoring the medicines through a pharmacovigilance program, and especially monitoring adverse drug reactions and adverse events, we can detect these problems and take actions to improve our PSM system to reduce the potential for harming the patient. So PSM is an important part because of the deficiencies in transport and storage. Now, PSM is not the only reason for adverse drug reactions in patients, but it can sometimes be the reason because of low standard medicines provided to the patients. And we're going to talk in the next session in how to address those areas. So what does this mean? You've got to have a pharmacovigilance program. It doesn't mean that you as PSM have to run it, but you have to take part in it. You have to be involved in it. Your country receives a grant from the Global Fund. It must have a pharmacovigilance program as a condition of the grant. But that might only apply to the medicines that Global Fund funds, like HIV, TB, and malaria, when it needs to apply to all medicines. So be aware, if you haven't got one, you're going to need one, and it needs to be set up. Okay, I'm going to pause there. I'm going very quickly for question and answers. Let's see what we've got in the chat box. Okay. No questions in the chat box yet. Everyone is too stunned. Okay. If you'd like to raise your hand or type a question in the chat box, I'll try and take any questions as we go through. If you want, you can just unmute and speak, okay, if that's easier for you. I don't see any hands raised, so Eowatafa, I see that you're unmuted. Are you going to ask a question? Quality procedures for medicines. Okay, yes, I will talk in detail in the next module, module 8. You will have about 2.5 hours on procedures for quality assurance of medicines. I'll talk a little bit more in the second session today about that, just a little bit. It's a long, complex subject. Happy to do it. Roper, I see you're unmuted. Do you have a question? No questions, everyone a bit shell-shocked from a rather fast presentation, yeah? You want, you can just unmute and ask a question. Benedict, you got your hand up. Go ahead, please.
Yeah, thank you. I want to, thank you for this opportunity, and I thank the management of Empower for this training. I want to ask about this pallet standards, and in most of the pallet we use presently, I rely mostly on the psychosanitary certificate that accompany the shipping document. Is that sufficient, even if nothing is stamped on that pallet used, and the shipping document contains the certificate of cytosanitary compliance? Thank
you. Normally it's enough if the certificate has it. Pallets are supposed to be labeled if they meet that standard, and they should be stamped, sometimes ink, sometimes a little metal tin plate on the pallet. Sometimes it's burnt into the pallet, it's branded. But you might have to look for it carefully on the side of the pallet. You might not notice it if you don't look for it. But yes, if you have the certificate, that's fine.
Okay, thank you.
Do we have any other questions? Anyone would like to raise their hand or put something in the chat box? I got one in the chat. What's that? It's important to call all health providers to strengthen the updates of the essential drug list and training of professionals. Yes, absolutely. Unfortunately, it's very hard to engage people in the largely bureaucratic procedure of updating essential medicine lists. It's essential, but it rarely gets the resources and the time it needs. You have to try and engage people in that. Where we've not been good in the public sector is engaging the universities and the NGOs to drive that process forward. We've tried to do it all ourselves rather than bring in other players. And I think bringing in other players will often bring some resources to us to enable it to do us. But absolutely, you have to get all parties involved, and that's difficult. Are there any global standards for managing donated drugs? Yes, there are. There's a whole document. It's now about 23 years old, I think, since we made the last version of it on how to donate medicines. We do reference it in the course. You can find it online just by putting WHO donated medicines into Google. You will find the document on the rules for donation of medicines and the standards that are required. And we recommend that all countries enforce that document. A feature of that document, which is almost never enforced, says that the donor should pay the storage and distribution costs in country. So that's one to raise with your government. It's not enough just to give the medicine, you should give some money for the storage and distribution as well. Okay, if we have any other questions, I'll take another few minutes before we go to round two. I'm sure you can find the WHO document very easily. WHO donated medicines, you'll find it online. And I'll try and post it up for the next webinar. Any other questions before we?
Hi.
Patrick, by the look of it. Yep. Go ahead, please.
Yeah, I'm just trying to get some insights from the international experts regarding the shortage of any sort of the medicine while working as a public health supply chain officer here in Nepal. We are just talking about the global standard for managing donated drugs or something like on that. But in the pandemic situation, Nepal is almost shortage with even with the paracetamol. As being a supply chain worker, how we can give some of our strategic management plan to cope with the existing shortage in the market. It might be some sort of out of track of the study team, but I'm just getting some sort of pressure from government agency as well as the local government agency who are imposed to manage the public health commodities during this pandemic situation. Can you please give me some idea how should I approach on this condition? But beside that, I just want to share that in Nepal is almost 40% it is under self-sufficient, and majority of the pharmaceutical products is around 60% are being imported from other country, especially India. and most of the raw material are also imported from India or China or somewhere else. And when I talked with the major pharmaceutical manufacturers, they are saying that we are on the scarcity of the paracetamol. So, being a supply chain management officer, how should I tackle this sort of situation? I'm sorry if I made any distraction from the course pattern. I really apologize for this. Thank you.
Oh, no problem. You have an issue now. We'll try and address it carefully and relatively quickly. Okay. There is a world shortage of some products. Many people will know that the corona pandemic was first identified in the city of Wuhan in Hubei province in China. I suspect most people had never heard of Wuhan before. What people don't know is that Wuhan is the center of the API manufacturing industry in China. That is the active pharmaceutical ingredient. Around 40 APIs are manufactured in Wuhan, in Hubei province. When they went into lockdown, the world supply of API stopped. India is known as the pharmacy of the world. It manufactures, but India buys 80% of its API from China. And where in China does it buy from? From Wuhan, which is in lockdown. So there is a world shortage of some medicines. The US FDA lists about 100 medicines which are in global shortage. They update the list every 14 days. You can find it on the US FDA website if you wish. So if you are trying to do this, then you can use the UN COVID procurement system. It's not just for COVID commodities. You can buy paracetamol through it. They will get you paracetamol. You can also use Global Fund. If you have a Global Fund grant, you're allowed to use the Global Fund wambo.org mechanism to procure, and they will procure on the world market for you. It'll be more expensive than you're used to paying, but you will be able to get supplies. So two sources, the UN COVID supply system and the Global Fund wambo.org system should be able to get you supplies of commodities which are in short supply. Okay. I'll just take one more question. I'll come back to that at the end if we've got more time, because it's a long subject. Private sector is responsible for irrational matters. They do not follow, they do not have SOPs to manage their medicines. It's largely true, but then we haven't been very good interacting with the private sector either. We want the private sector to comply. We have to bring them in as partners. We have to discuss, we have to work with them as well. So yes, absolutely true. We've done a number of programs of providing government medicines to the private sector to make sure that they followed the standard treatment guidelines for situations like tuberculosis, providing first-line drug kits to the private sector to give to patients to ensure that they followed standard treatment guidelines and rational medicine use. Much more can be done with that, but it does mean that we have to learn to cooperate with the private sector and not regard them as a big evil all the time. We have to learn to work together with them. Okay, I'll just check and share the presentation. Yes, the presentations are shared. Okay, time's getting on, so I'll go to part 2 of the presentation and then we'll come back to the Q&A session at the end. Okay, so what do we actually do around this pharmacovigilance? Well, let's take a typical situation where you have been put into the National Drug and Therapeutic Committee as the procurement supply chain representative. You're there on the committee and there's doctors and pharmacists and nurses and all different people. And you've got 3 adverse drug reaction reports. 3 reports in from doctors in the field that this drug has caused a problem. And the first problem is often these reports are not very good. They're vague. They don't include the batch lot number of the medicine. They might report something like the patient had nausea and was vomiting and the medicine had a bad smell. They don't even always include the name of the medicine. So there's a problem. But is it anything to do with PSM? And what should PSM do about it? So that's the first issue. Not all pharmacovigilance problems arise from PSM, but some do, and we need to address the ones that do. So firstly, recognize that these adverse drug reaction reports are often incomplete. Somehow clinicians never feel they have the time. And anyway, it's not their job to investigate. It's your job to investigate what's happening. We can't wait to react. By the time that we have full information, it can take months. Patients could be at threat. So we have to react and we have to consider patient welfare. You're always going to need more information. But there are actions and decisions you can take now in conjunction with other parties to address the situation. And I'm going to go through that. The graph here just shows typical reports, ADR, suspect drugs information. Less than 50% of the reports had any information about the drug. So we don't have a good baseline to start from. The first decision is this a high-risk medicine? And what do I mean by a high-risk medicine? Well, we have two classifications. One is called a pinch, and the other is the WHO stability at-risk medicines. So the first job we do is this a high-risk medicine? Is it on the high-risk list? And on the screen there, you can see the A pinch medicines there. Is it insulin? Is it a narcotic? These are high-risk medicines. They're known to have quality problems. They're known to have issues in storage. There's one other reference. There are basically 5 criteria we have to use, and we'll talk a lot more about this in the quality assurance module, which is the next one in the course. Does it have a narrow therapeutic window? Does it have bioavailability problems? Is it from a new supplier that I've not used before? And is it on the stable dosage forms list? If it's in those areas, it's one of the high-risk medicines. We'll talk a lot more about each of those areas and explain more detail about them in the next module. For now, it's enough to recognize there are certain categories of medicines which are more prone to quality issues than others. These categories are long established and the problems are well known. So if the medicine is on the list, we should suspect immediately that there could be a PSM issue. So here is a table of the narrow therapeutic index drugs. And what that means is these drugs have to have exactly the correct dosage. Just a little bit off and it's going to hurt the patient. So there's not many items on that list, just digoxin and phenolphthalein and warfarin on the list there. That's the first list. Just check, is it one of the medicines on that list? And the next list is bioavailability medicines. Look through the list. What's the problems on there? Is it on that list? Because if it's on that list, it could have a bioavailability problem. You don't have to know too much about bioavailability, just is the medicine on the list, yes or no? And does it have stability problems? And here we have medicines with known stability problems, and paracetamol liquid is one with a lot of stability problems because it grows bacteria. You get black lumps floating about in it. It's a common problem with paracetamol liquid. And there are other ones, retinol, vitamin A is also a common problem. So is it on that list? So if the medicine is on any of these high-risk lists, then it should ring the bell. It could be a PSM investigation. Start the PSM investigation. And the first thing you need to do is get hold of some of the medicine. If you've got the batch number, you can go to the store and maybe you've got some of that batch still in the store and you can check that. If not, you're going to have to get some sent to you from the site. The first one is a quick visual inspection. And by a visual inspection, I don't mean just look at it. I mean follow the formal, official visual inspection checklist. And if you're not familiar with that, there's an example on the next slide that I'll show you, which is from the Tanzania Drug Inspector's Handbook. The link is on the screen if you don't already have it. And here is an extract, it's 3 or 4 pages of all the items that you do for a visual inspection. It's not just look at the medicine, go through the checklist, check that it is correct. Okay, go through each item, and if it fails any of those tests, then I know that there's a quality issue, there's a quality problem, and I need to discuss that with DTC about withdrawing the medicine from use. So use the Drug Inspector's Handbook and the visual inspection as a quick and easy way. It should only take you about 15 or 30 minutes to do the visual inspection. How can you get more information? You've got to get the medicine. And you're going to do a visual inspection and then a rapid testing technique. And there are a number of those available. And for reasons that are beyond me, countries never want to use them. Often I go to a country and find it sitting in a cupboard completely unused. On screen is one that's been used in Ghana, which is called TrueScan. You don't even have to open the blister. You can do it right through the blister coating. And it will give you an immediate reading, pass-fail, on the quality. It's only about plus or minus 10–15%, so it's not completely accurate as a lab test, but it's good enough for a quick screen. Is there a real quality problem with this medicine? And that's called the TrueScan. There are many different devices. It's a Raman laser, infrared spectrometer, handheld. To give it its full title, they cost about $45,000 each, but UNDP has been donating them to a number of countries. That will give you a quick test. Other methods are on the screen. There's a Fourier infrared transfer technique. There's the mini lab, which is a wet chemistry technique, but it comes in a briefcase and it takes about 2 hours to do a quick test. Gives you the results immediately. You can do it on the warehouse floor. Doesn't need to go to a lab, because a lab test will probably take a number of months. So you can do a quick screening test. And we'll talk a lot more about these screening tests in the quality assurance module. But there are techniques where we can do quick screening straight away on the medicines. Take all the decisions in full cooperation with the Drug and Therapeutic Committee. The DTC should lead, but you should be fully aware and fully involved in what's happening, because it could have arisen from storage and distribution. So rational medicine use and pharmacovigilance are essential for all countries. And poor PSM operation can increase irrational use because of substandard medicines. So it's the duty of PSM to maintain the quality of the products and have and take part in rational medicine use and pharmacovigilance activities. The key point around this is the cycle. Irrational medicine use impacts procurement and supply chain by disrupting quantification. Poor quantification leads to stockouts, which impacts rational medicine use. PSM does not embrace rational medicine use. PSM can never operate effectively. It's impossible to prevent stockouts without rational medicine use. Many PSM staff still do not recognize the importance and relevance of rational medicine use. So you'll need to advocate for rational medicine use. It's exceedingly cost effective and it saves a lot of money. You will rarely be in charge of PSM, but you should understand the need to take part and contribute to the program. There are lots of strategies for addressing RMA. They are well known, and pharmacovigilance is an essential part of those strategies. Went through that very quickly to give us more time for Q&A, so we can have Q&A on this and any other subjects you want to lead. Okay, your chance for questions again. I don't see anything in the chat box, so if you just want to unmute and ask your questions, and I'll take questions on any area. Just as I tried to address Nepal, I'll address any area that you have in mind. Okay, so I'll take questions for 10 minutes or so now. You can just unmute and ask the questions if you wish.
Hello.
Yeah, go ahead.
Yeah, this is Taban from Northeast Syria. Thank you very much for this very nice presentation. In fact, actually, issues to do with pharmacovigilance and issues related to adverse drug reactions and poor feedback from sometimes maybe consumption of substandard drugs is always a problem. And like you have said, mostly clinicians consider this part is not like most related to them. They always focus on treating patients or clients rather than doing some follow-up. Yes, I've realized, I'm from South Sudan. I've realized in the package for a component for dispensing practices where dispensers could sometimes give enough information for patients receiving drugs, this part is always not being taken care of in terms of how, for example, if there is any adverse drug reaction or any, let me say, signs of poor feedback as a result of actually poor quality of the medication, how will now the patients report back? Because actually dispenser is the last point in the supply chain where patients can always receive their medication. So I don't know, in most cases, how can we handle this? Yeah.
Okay,
Back to you.
Okay. It's not just clinicians that can initiate adverse event reports. The dispensing pharmacist can also do that, as can any of the nursing staff who are in contact with the patient. So anyone who has patient contact can initiate the adverse drug reaction or adverse event report. So if the patient complains to the dispensing pharmacist, he can complete a report and send it off. But also, he can ask the supply chain within his hospital or building to undertake the visual inspection. And you've got the Tanzania Drug Inspector's Guide there in order to check it. You can do an immediate visual inspection. That won't catch everything, but it will catch quite a lot. And that's worth doing straight away to see if there might be a problem there. Pharmacovigilance program extends to all people who have patient contact. Pharmacists, nurses, clinicians, physiotherapists, paramedics, anyone who is involved with them. Okay. Pharmacovigilance is being ignored, although in some countries UNDP Global Fund supports for HIV. Yeah, it often is ignored. It's a case of us having to advocate it. As we've said throughout this course, our aim is to empower you. It's not enough that you know what to do. You have to be able to advocate for what to do. And that means advocating for rational medicine use and pharmacovigilance. And PSM has not been good at that. For a long time, PSM has considered it's not really their job, somebody else's job. And we have to embrace rational medicine use and pharmacovigilance as PSM and try to drive it forward. We don't do everything, but we are a key player. And we have a voice in advocating to move it forward. No Center for Reporting and Feedback to the facility. I'm afraid that is often a major failing in pharmacovigilance. They send a report and they never hear about it again. Good pharmacovigilance programs always send the feedback. There's lots of models to follow for good pharmacovigilance programs. They're relatively cheap to set up. Doesn't cost a lot of money now to make a pharmacovigilance program. It does need some training. Okay, if we have any further questions. Oh, quality of temperature sensitive drugs like oxytocin. Okay, I'll take that in two parts. The way we assess temperature exposure is through a system called mean kinetic temperature, MKT. That's a complex calculation. The degree level pharmacists might just remember it from one of their lectures. They'll talk a lot more about it in the quality assurance of medicines course, but basically it allows for the fact that you can go over temperature for a short time, provided you stay within the mean kinetic temperature. Now, this used to be a very difficult and onerous calculation, but with modern equipment, you can buy an MKT monitor for around $20, and that will monitor the mean kinetic temperature. You can put that with the medicine, check it each week. How is your exposure to temperature, and do that. How can you measure the quality? The rapid diagnostic techniques we've talked about, that is handheld Raman laser infrared or Fourier transfer infrared. These techniques are available now. They're not as good as lab analysis, but they are immediate, typically 1 or 2 minutes to get the analysis. And they'll give you a good guide as to the quality of the medicine. They're available now, and they should be used. And you'll find they are being used in Ghana and Nigeria. Other countries should be rolling them out now. It's a quick way of checking. QC, QA activities in the supply chain vis-a-vis in the regulatory sector. Which sector? The answer is both. Both sectors need to do. But if the medicines are in the public supply, it is the public responsibility. So supply chain should be doing it. During importation into the country, that's clearly regulatory. Regulatory's role extends into the private sector, and they need to be looking at the quality of medicines across the whole country. Are there resources in the supply chain in the private sector? Yes, some countries have it, some don't. It varies hugely. In some countries, the private sector does nothing. In others, they do. And what's driving that in the private sector is the insurance companies. So because of the rise in health insurance, the insurance company will only pay if the hospital, if the clinician follows the standard treatment guidelines. So if they decide they want to use a different medicine, that's fine, but the insurance company won't pay. So we're seeing in somewhere like the USA, which is largely private medicine, we're seeing good rational medicine use because the health insurance company is insisting on it. They're forcing rational medicine use because they understand the economy. They only pay for the medicines which are in the standard treatment guidelines. After establishing that there is a serious adverse drug reaction from patients, who is liable for that, and do patients get compensated? That's a legal issue that is outside the brief of procurement supply chain to determine that situation, and it varies between countries. In some countries, the government has what is called crown immunity. They are immune from prosecution. In other countries, they can be prosecuted and you can get compensation. So it's varying depending on the law of the country. There's no one-size-fits-all answer to that, but there is a liability, and we in the supply chain have to recognize the liability for what we're operating. Again, if you just want to unmute, I'll take any audio questions as well. And I'll take questions on any subject, just like Nepal. If you want to ask about shortage of supply, I'll try and answer those as well. Well, rational medicine use is not just about sourcing, it's about using the medicines. So they're controlling your sourcing, that's good. And how the PSM in poor countries can respond to need is given to healthy government. Okay. So yes, the donors will often dictate the source increasingly now, particularly with Global Fund. They'll dictate where you must buy it from. But that's just part of the equation for rational medicine use. You have to have it in stock, and that means you're doing the quantification correctly and that you're storing and distributing it correctly. How can you respond to needs when production is given to the government? It's very difficult. We have to advocate, we have to liaise, we have to fight, frankly, with the government all the time to get enough resources for rational medicine use and for adequate supplies of medicines. Many countries' funding levels for medicines are so low that we are never going to be in stock. Your country is buying less than $12 per capita for medicines. You're never going to be in stock of essential medicines. Doesn't matter how good your PSM is. So you have to have adequate funding levels, and that means advocating for them. And throughout this course, we've tried to give you the evidence and the information to empower you to advocate. I think we've got time for one last question if anybody wants to ask. And I'll take any subject related to PSM. Okay, I think everyone's a bit shell-shocked on a very high speed and intense presentation. There's a lot to think about there. Again, when we come to rational medicine use in the quality assurance section, which is the next module, a lot of this will make more sense to you, will be more available. I know many of you are trying to cope with COVID and especially COVID vaccine rollout at present. So I'll stop now and give you time for your day job. Thank you very much for being with us today. I wish you all a pleasant and safe journey home and good hunting in procurement and supply chain management. Thank you all for being with us.
Thanks, Prof.
Okay.
Thank you, Prof. Bye-bye.
Okay, bye to all. Good night to all.
Good night.
Thank you.
Thank you, Prof, and bye.
Bye.
Thank you, Prof.
Bye to all.
Bye.
Au revoir.
Au revoir.
Goodbye. Stay
Thank
safe.
you. Bye.
Okay, bye.
Bon voyage.